I am Joe Ripsum. Welcome. I'm a Director of Child Welfare and Youth Justice Policy here at the Annie E. Casey Foundation, and it is very exciting to have so many people join us for this webinar. Looking at the registrations, we are joined by folks across many sectors today: Medicaid, youth justice, children's behavioral health, child welfare, young people and parents with lived expertise, service providers, education, healthcare, and many more. This work is exciting, and it's also very complex. I say it's complex because to do it well, it requires diverse people, communities, systems, and payors, many of whom have never worked together before. And it requires them to design a new way of working together, ideally in a way that does not center the different systems' needs, but rather centers the needs of the young people and families who experience those systems. It's complex technically, it's complex relationally, it requires high technical skill, it also requires high levels of trust. It is truly an adaptive leadership challenge. And while today we're talking about a specific, potentially narrow policy change, narrow if we choose to implement it as a narrow policy change, we're also talking about a potentially transformational policy change if we choose to use it that way and catalyze a new way of ensuring that young people and their families receive the care that they need through community-based supports funded primarily through Medicaid without unnecessarily tethering them to the justice system in order to receive the care that they deserve. I know I just said a mouthful and I probably lost many of you, but hopefully through the next hour, you'll start to see what I mean. So to that end, today we don't plan to touch heavily on the technical aspects of this policy change. We will not spend so much time there. That ground has been covered by us in the printed materials and on other webinars, and we're going to share links to those materials in the chat. Rather, we want to use most of our time today to help folks think beyond those technical requirements and move into how one might implement this work to meet the needs of those we serve based on what we've seen in places who have done similar work. All of that said, I want to remind folks that this is complex work. The people charged with implementing this work are mandated to do so on a very tight time frame, as you'll see. So we have to offer one another grace as we move into this work, and we have to recognize that jurisdictions may need to start in one place to meet compliance deadlines as they work to something that looks more like the vision that we hold for young people and their families. So a little bit about the Annie E. Casey Foundation for those who are not familiar, given that we're reaching a pretty broad audience. We are a private philanthropy that builds a brighter future for the nation's children and youth. We want to make sure that all young people have the family connections, relationships, communities, and educational and employment opportunities that they need to thrive. We focus on children from birth through their mid-20s because research shows that young people are still growing and developing until then. We concentrate on young people and families with the greatest need, including those who have low incomes, live in high poverty communities, and are involved in the child welfare and justice systems. And we know that children and families of color often face the greatest barriers to succeed. Using data as our guide, we develop innovative ideas to address the challenges these young people and families face. We work with a diverse set of allies across political lines and across sectors to invest in the most effective strategies based on solid evidence to help them reach as many children and families as possible. We know what works. Sustainable solutions emerge when families and young people who have experienced the systems are deeply involved in designing the solutions to those problems. And with that, I am going to pass to my colleague, Liz, who will move us forward.
Thank you, Joe. So as Joe shared, we have some great speakers here today. So in addition, my colleague to myself, Liz Buck, we have Alyssa Gelber, a Senior Program Officer at the Center for Healthcare Strategies. We have Jade Kissy, a Program Associate at the Center for Healthcare Strategies, who have been instrumental in developing many of the resources that we'll share with you in the chat. But as intended, we really wanted to focus this on a discussion of leaders who are implementing this work really bravely in their states and communities and have set out to do courageous visions to improve outcomes for youth. So we have Dr. DeLacy, Executive Director at the Family Support Organization of Union County, New Jersey. Jennifer Strohecker, Utah Medicaid Director at the Utah Department of Health and Human Services, Amy McCormick, Associate Bureau Chief for Field Services in New Hampshire at the Department of Health and Human Services, and Daryl Tenney, Bureau Chief, Bureau for Children's Behavioral Health at the New Hampshire Department of Human Services. And we'll, as we shared, get in a more robust discussion with them on great things that they've implemented in their states and communities. Just a little bit about who we are at the Center for Healthcare Strategies, CHCS. So we are a national organization really focused on improving the healthcare delivery system in the United States. And our intended focus is really focusing on adults, youth who are served by the Medicaid program and the CHIP program. We partner with these broad range of stakeholders, including state agencies, national partners, community-based providers, managed care plans to do that work successfully. And as like the session will outline, it really takes everyone to do this work well. So as Joe alluded to, we have a robust agenda today. We'll spend some time talking more deeply about what this vision looks like. What are we talking about in the vision? We will ground you in some of the requirements, just because it may be new to some folks who are on the line, but then we really want to spend the bulk of the discussion on a facilitated conversation with state and local leaders who are doing this hard work in their communities. We will have time for a Q&A portion. And actually, some of our colleagues and state leaders have agreed to stay on a little bit longer should there be a lot of conversation and questions. And so we encourage folks, we recognize there's a lot to this. So we're excited to stay a little bit later than the 2 p.m. timeline. So I'll pass it to my colleague, Alyssa, who will talk about this broader vision.
Thanks, Liz. You can go to the next slide. So as we think about the new Medicaid requirements, which we will be talking about in more detail in a few minutes, it is really important to keep in mind that there is a critical connection between youth health and well-being and incarceration. When the health and well-being needs of youth and families are met, when they are cared for and supported in the ways that we see on the right side of this graphic, through things like quality healthcare, housing, transportation, youth and families thrive together in their communities. When these needs are not met, when youth and families are not supported in these ways, as seen on the left side of this graphic, youth are more likely to be incarcerated. As we know from the research, incarceration exacerbates health and well-being needs, setting up a cycle of re-incarceration and poor outcomes. Re-entry presents a key opportunity to identify and address these unmet health and well-being needs in a meaningful and sustainable way, setting youth up for healthy futures in their own communities. Next slide. It is for this reason that we encourage states to think about implementing these new requirements in ways that support broader health and well-being goals for youth and families. And you're going to hear this afternoon from states that are taking this approach and the many benefits that it can yield, including reduced incarceration and improved outcomes for youth and families in their states. Jade, I'll pass it to you.
Thanks, Alyssa. So, as Alyssa mentioned, this legislation poses an exciting opportunity for states to help meet the needs of their juvenile populations. And for states that are focused on advancing their equity strategies, these new requirements present a key opportunity for addressing racial, ethnic, and gender disparities. As many of you are already aware, there's a disproportionate representation of youth of color, particularly Black youth, in the juvenile justice system. Youth of color have a higher risk of entering incarcerated settings, being readmitted into those settings, and experiencing other social risk factors that contribute to adverse health outcomes. With that said, any approach that states are using to take advantage of these new opportunities need to take into account these disparities and embrace an equity focus into their strategies, especially when considering community-based partnerships. So I'll pass now to Liz to provide an overview of these new requirements and opportunities under Medicaid.
Thank you so much, Jade. So as Joe shared, we won't go into very nitty-gritty detail, but we do want to kind of frame the conversation to share some of the highlights. So we're specifically building upon Support Act legislation, which previously mandated that eligible youth would for Medicaid would not get their Medicaid coverage terminated. The topic of the conversation today will really focus on some of the requirements with the CAA and how states are being bold and thinking through strategies. But we do want to lift up a few things that we think are helpful for the audience as well. So many states, including Jennifer, Medicaid director in Utah, may mention their CMS 1115 demonstration program. So that's an opportunity that some states are electing to do, which can actually just expand services and resources for youth in addition to these requirements. And then my colleague Ruby will share in the chat, the CAA in 2024 actually makes funding available for some state planning support to be able to implement these requirements. And actually that NOFO is out now. So if ever there's an impetus to get started and where there's resources to support you all in those efforts, we want to amplify those. So at a very high level, the requirements of the legislation, the reason why this legislation is particularly critical is the legislation partially amends the inmate exclusion policy. So within the Medicaid program itself, there was a barring essentially of federal Medicaid dollars going to youth and adults who are incarcerated through the Medicaid program. And so this legislation really changes that. It recognizes that there are often poor transitions of care, often youth who leave incarceration don't have their Medicaid benefits or services lined up. And so this is meant to ameliorate that. So the legislation states that as of January 1, 2025, you have that deadline correct, 30 days prior to schedule release, that states are covering screening or diagnostic services that meet reasonable standards or is indicated as medically necessary. So that can include behavioral health screening, diagnostic services, and that 30 days prior to release and at least 30 days post-release, so pre-release services and post-release services, that states are covering targeted case management services as well. And I'll transition to my colleague Jade to describe a little bit about what we mean by targeted case management.
Thanks, Liz. So as Liz just mentioned, targeted case management or TCM is an important component of the upcoming requirements. The coverage of TCM is an opportune means of connecting youth to these critical services 30 days prior and 30 days post-release. According to CMS, these critical needs do not only need to address the physical and behavioral health needs of youth, but also the health-related social needs like developing safe decision-making skills, building relationships, opportunities for meaningful employment, access to nutritious food, and the others listed on this slide. And according to these new requirements, TCM has 4 required components, which is assessment of the need of medical and other health-related social needs, development of an individualized person-centered care plan, referral and service linkages to these services, and then ongoing monitoring and follow-up activities. The CMS guidelines make it clear that while providing these services and targeted case management prior to release is critical, the implementation of these services should not result in a delay of youth's release or lead to further involvement in the justice system. I can go to the next slide. So there are 3 categories of youth eligible for these new requirements: youth under 21 eligible for Medicaid, youth under 19 eligible for CHIP, and then youth under 26 who were formerly in foster care services. And according to CMS guidance, the requirements apply to juvenile detention and secure juvenile settings, local jails, tribal jails and prisons, and state prisons. At this time, the requirements do not apply to federal prisons. So I'll pass it back to Liz to go over some of the optional provisions of the legislation.
Thank you, Jade. So the requirements that we talked about require to youth who have been adjudicated, but there are new opportunities also for states to continue to think boldly. So under the CA, states can decide to provide Medicaid and CHIP coverage beyond those services and for youth pending disposition of charges. So some states are considering that. And so, partnering together with your Medicaid agency and juvenile justice agency will be really critical to determining if that makes sense for your state. So there are many partners that are critical to success. And again, we want to leave the discussion for them to talk more about it. But as you know, the populations are broad. We recognize that there are many systems that youth are coming from. And so there are going to be a lot of wide-ranging partners. And as Joe said, many who haven't yet partnered before. So community supports, community-based organizations, faith-based organizations, local jails, foster care systems are all going to be critical partners, and that's not exclusive to the Medicaid agencies, behavioral health agencies. You can see them all here. This is sort of the minimum of organizations that will just be critical for successful implementation to ensure that youth have the services that they need. And then in our report, which may have been shared already in the chat, in our research and conversations with states and communities, we really lifted up 3 strategies that rise to the top in terms of what is effective in getting to the vision. So one is states are engaging in robust cross-system coordination. They'll talk a little bit more about that in detail. States are working with a formal and informal community supports to improve access to well-being and care for youth who are leaving these settings, and then expanding and leveraging services and supports outside of the justice system has been really critical for success for many of these states. So I'll turn it to my colleague, Alyssa, to get us started in a discussion.
Thank you, Liz and Jade. We are thrilled to have with us today 4 esteemed panelists to speak with you all about their experiences in early implementation of the new Medicaid requirements in their states and generally how they were thinking about their approaches. So I will take a quick minute to introduce them. Jennifer Strohecker has served in state government since 2018 and is currently the Utah Medicaid Director and the Director of the Division of Integrated Healthcare. Dr. DeLacy Davis is a retired police sergeant and a retired school principal, and currently the Executive Director of both the Family Services Organization of Union County, New Jersey, and the New Jersey Alliance of Family Support Organizations. Amy McCormack is the Associate Bureau Chief for Field Services for the New Hampshire Division of Children, Youth, and Families, serving the state of New Hampshire in various juvenile justice positions for over 17 years. Daryl Tenney is the Bureau Chief in the New Hampshire Department of Health and Human Services, where he supports New Hampshire's children's system of care. Thank you all for being with us today. Let's talk first about vision. So we opened the program today by talking about the importance of implementing these new requirements in a way that supports broader visions of reform for child, youth, and family well-being. This has been a long-standing approach to regulatory change in the state of Utah. Director Strohecker, could you talk a little bit about that?
Yes, thank you. Well, from the start, we have seen this as an incredible opportunity for our JJYS and correction systems, DCFS, behavioral health, Medicaid programs, and other community partners to build a coordinated and integrated system of care for the individuals and families that we serve. But at the heart of this is really the individual. We see this initiative as an opportunity to really address the longstanding silos of care that have existed in the care continuum and that do result in less than adequate outcomes sometimes. So through Utah's opportunity to implement both the Consolidated Appropriation Act youth justice requirements alongside our adult 1115 justice waiver, we do envision a system of care that is standardized and seamlessly supports the individual and provides three things. Number one, a pillar of whole person care that really comprehensively identifies behavioral, physical, and social health needs. It really aims to coordinate and close gaps through this continuity of care and creates an upstream investment in comprehensive healthcare services to help us achieve our goals. So to really accomplish this, we've approached this work through a wide lens. We recognize the role of Medicaid as a foundation of this work, but it is not strictly a Medicaid program. This is an opportunity for us to engage our justice partners, community stakeholders in our much broader goals of improved health outcomes for individuals and community well-being. So we are intentional about framing our work around these larger objectives and aligning our collective work with these opportunities in mind to think about how this can better serve youth and families who interact with our system and depend on them for essential services. And while it's great that we can access a platform in these settings, a platform that really does transformational change, our hope in Utah is always to keep kids out of these environments. The reintegration aspect of this waiver is so helpful, but we believe it will help support our objectives in serving and supporting kids in their homes, schools, and communities as well.
Thank you, Director Strohecker. Amy and Daryl, could you talk a little bit about how New Hampshire has developed a shared vision across state agencies and stakeholders, and how this will inform the work you do around implementation of the new requirements?
Absolutely. So I'll take the first part of that, and I'll hand it over to my colleague Amy McCormick. Jennifer, I'm going to echo quite a few things that you had mentioned in yours. New Hampshire Department of Health and Human Services has really made a strong stance to shift the de facto system of care that was provided in the child welfare system to a system of care that is available to all children and families in New Hampshire. And while that has taken a significant amount of time to do that, that was a real key vision to ensure that families are preventively accessing care to not even get to the point of needing to be incarcerated or become involved in the juvenile justice transformation system. New Hampshire's system of care framework is really designed with key internal and external partners to ensure that children and families and their families receive an array of services across that continuum of care, and that all services and supports adhere to system of care values. That's a real important piece to New Hampshire's system overall. So for New Hampshire, this has allowed for the integration of the new requirements to fit within that system of care framework as seamlessly as possible. And a lot of the work that we've done up front with the system of care development has allowed us to really think about how do we integrate more impactfully and utilize key services and support like enhanced care coordination or more intensive care coordination that is available across our communities to help coordinate those key transitional components associated with this these new requirements. And so with that, I'll hand it over to Amy McCormick to talk a little bit more around those cross-agency structures.
So we are fortunate here in the state of New Hampshire that we have embraced system of care and system of care values, and juvenile justice has wholeheartedly embraced those philosophies of being trauma-informed, culturally and linguistically competent, a commitment to community-based programming, and having youth and family voice be part of the process. Juvenile justice in New Hampshire has transformed our system to embrace utilizing a strengths and needs CANS tool, which has also created a consistency within our behavioral health, creating a shared vision for outcomes for youth and their families. We truly believe in meeting families where they're at and utilizing their strengths to reduce their needs, but while also embracing that youth and family voice. We are having wonderful outcomes related to our efforts to utilize community-based programming and diversion and reducing the number of youth for incarceration and at our detention and commitment facility. And we're really proud of where we've come and look forward to what the future brings. We also want to recognize that the requirements that are being instilled are not why folks should be thinking about changing their system, but changing their system because it produces better outcomes for the youth and families, and using the new requirements as a way to help fund it on the back end.
Thank you, Amy and Daryl. Dr. Davis, Amy talked about family voice and meeting families where they're at. I know you have done a lot of work in this area. Could you tell us about why family-centered approaches are so important in working with youth who are transitioning from incarceration and what this work has looked like for you in New Jersey?
Certainly. So we know that it's a best practice, first of all, because parents understand better than most people what the needs are of the children, what the needs are of the family. And as a parent of one birth child and 4 adopted children, when one of my daughters was being released from 11 months in a juvenile facility, we and she clearly understood her areas of strength and areas of challenge. And so we worked with a community-based organization to develop an action plan and a program that magnified her strengths and developed her areas of challenge. For example, there was counseling for it, not only for her, but for the family. There was also a female mentoring program that she went to weekly that was designed by young people in the community. There was summer camp that she went to through the police department's Police Athletic League, again, youth design, and then family supports for her birth parents, as well as us as an adoptive family, so it could be integrated and we were all on the same page. That's just one example. That's a quick nutshell of all the services coming together and everyone collaborating in the community.
Dr. Davis, you touched on this a little bit, but what are the range of needs you're seeing in youth who are exiting incarceration?
Oh God. So when they're coming home, their behavioral health needs, their physical needs, we talked about some of that around just medical care, housing needs, education, social, emotional learning, developing healthy relationships, how to build friendships, developing their unknown talents. You know, one of the things that we spend a lot of time on in the police department with young people is identifying, what do you love? What are you really good at? Sports, performing arts, personal interests, safety and security in the community for them and from them for some of our young people, identifying resources in the community and then matching them to these needs. For example, we had a young man that had done 11 years behind bars. He comes home, but we started a year before he came home working with him and then identifying he wanted to be in the culinary arts. Identified a community program that was teaching culinary arts, identified an agency that would pay for the tuition, and then we also had to hold his hand for 2 to 4 months to get a job, and now he's been home 5 years, no violations of parole, and this young man is doing extremely well, and now we utilize him as a model for other young people. That's just a quick example of going through these steps, and it takes some time, but these are their needs immediately when they come home. And one of the things we do in Union County is that we have reentry simulations so that we can help identify what the needs are for the community groups and the agencies and other providers.
Thank you. On that note, let's talk a little bit about community providers. Daryl, maybe you can kick this one off. Can you talk about the importance of working with community providers, what that's looked like in New Hampshire, and maybe how you're thinking about those relationships as you move into implementing these new requirements?
Yeah, thank you very much. So incredibly vital. And one of New Hampshire's perspectives is that for a youth to transition back to the community, there needs to be a full continuum of care to be able to support a family, a youth and family's needs and strengths in a family setting, in a community setting. And so this New Hampshire System of Care framework has really provided a partnership and collaboration that allows providers to not just talk to each other, not just collaborate, but to really identify how to refer to each other, understand the needs and strengths effectively, to talk the same language. Amy had reflected on our standardized assessment, the child adolescent needs and strengths tool that is utilized across the New Hampshire System of Care. And really having that uniformed language to talk about needs and strengths is important, but really cultivating and ensuring that the system of care really develops an opportunity for providers to come together to talk about that is really key. So across the system of care, team and through that continuum, providers do meet regularly. We have system of care advisory committees. We have tiered working groups that come together frequently to discuss needs and gaps, and to support those transitions for this particular population that we're looking for. It's really key to talk about how do we reduce the number of youth that are even in that situation, but to prepare for youth to return back to their community, it's even more vital to bring community partners to that table. And I just want to make one last echo to having a standardized tool like the Child Adolescent Needs and Strengths, to have a youth tell their story in one sector of the system, and to be able to have that story follow them, be updated, talk about their outcomes, improve their needs, talk about their improvements, celebrate their successes, stand up or put on a pedestal their strengths and what they're doing well, is really key for our community providers to talk about. So I want to drive that part home as part of that question. Thank you.
Thank you. Amy, did you want to add anything to that?
I think Daryl summarized it so well. But the one piece that I just want to make sure that folks understand with our structure is what Daryl's talking about is truly separate from our child welfare and juvenile justice system. Folks do not have to have court involvement or oversight to access the community-based program, high fidelity wraparound, enhanced residential care coordination that Daryl has mentioned. But embracing the one tool across multiple systems to tell that youth story and follow them, to track the outcomes and improve those strengths, reduce those needs, was really important, even though we are talking about community-based serving systems that are not part of state government.
Thank you. Glad you added that important piece. Let's talk for a minute about results. Director Strohacker, maybe you can kick this one off. What are the tangible benefits you have seen result from the collaborative partnerships between Medicaid and Justice in Utah?
Thank you. So to start, we have to acknowledge the present state to really consider what we've set out to do and what we've accomplished so far. And I think we've acknowledged from the start that youth and individuals today may move through many hands, and while we have shared goals and objectives, some of them are not well coordinated. It was already stated, a youth may leave a facility, they may not have Medicaid eligibility, they may have established a good level of treatment and care, and then there's a gap, right? And so we don't always achieve these goals. So in our state, about a year ago, we actually came together and on the ground level built project teams and identified some key people who would lead out on this project, really mapping current processes and envisioning a future state. But at the executive director level, this was also equally important to make sure we had buy-in engagement from all the partners, from our correctional partners, community stakeholders, and our government staff that are doing this work as well. We do have some early milestones that we are really proud of. I mean, first, one that we acknowledged from the start is some of us speak different languages, right? Medicaid, we'll acknowledge, is a language in and of itself, and certainly working in our different areas, it can be a challenge to interpret what the others are saying. So by really acknowledging and working through that, I think we've been able to really help and push our justice partners to see the work through that Medicaid lens. And it's also been helpful to have Medicaid really understand and be able to see it through those justice spaces as well. And as we've done this work, we've been able to really establish a shared vision. While continuity of care is a concept that we understood and we've talked about, bringing these spaces together, we've really been able to envision the platform and vehicle to make that a reality across our state and our programs end to end for both youth and adults, really. We've been very intentional to define our goals and spend time looking at what are our goals that we want want to accomplish as we focus on health and well-being as part of our reentry strategies, we really develop this broader vision and focus on the framework that really supports us achieving these goals over the time as we are building and kind of establishing our standards of care. The collaborative efforts between Medicaid and justice in this context does create a more rehabilitative and sustainable approach to reducing incarceration and really supporting healthier communities. And last, I'll say that we made a commitment early on as we defined our goals around really identifying what those outcomes are and committing to a standard process of data collection and measurement so that we have visibility into what works and what doesn't work. And so this really does help support the continuum of care and helping us just stay true to our larger vision that we established from the start. So thank you.
Thank you, Director Schroehecker. Same question, Amy and Daryl, if you wanted to jump in on this as well. What have you seen over the years in terms of the benefits and the results of those collaborative partnerships to support youth involved in the justice system? And then how do you see that kind of building on that from the opportunities that come with these new Medicaid requirements?
Daryl, do you want me to start?
That'd be great.
Okay. We are very proud of the work that we're seeing with outcomes regarding our reduced reliance on court intervention, the number of youth we're diverting as a utilization of our CANS assessment process conducted by our probation officers in our state. We are referring 75% of our youth either to behavioral health or community-based interventions. We have a significant reduction at our detention commitment facility and population and census. It's a 144-bed facility, an average daily census of around 14 youth. We're embracing a new trauma-informed facility being built with a capacity of 18 beds instead. We have a reduced length of time of youth on probation with reduced recidivism as a result of embracing more of the strengths, implementing services earlier on, being more youth and family-driven plans that are created, and overall just really improved outcomes and lengths of terms of youth who end up on juvenile probation in our state by embracing the community-based supports and interventions that are established. We have excellent outcomes with the number of youth who are referring to behavioral health with high fidelity wraparound model, with 100% of the youth being eligible for the service intervention being provided because it's driven by the CANS outcome scores that we've generated, with 89% of the youth enrolling in that service from the juvenile justice referrals on a voluntary basis, being served in their communities on their own accord without court oversight or probation involvement. The outcomes from that are significantly improved than youth who are forced to enter into these systems from someone else telling them what they need or their families telling them what they need rather than embracing their own voice and value, family values in the process. So Daryl, please feel free to add.
Oh, that's great. You did a great job, Amy. Thank you. And I think the one piece that I would add from that is once a youth is referred or connected with high fidelity wraparound and other community-based services across the continuum, we're seeing a significant reduction in recidivism, youth that are needing to become re-involved in juvenile justice across the board. We're seeing youth and families really connect to more community-based services, as Amy mentioned, or significantly being impacted by that process. It's working, and we're really understanding that families' needs can be met effectively in the community as long as they're coordinated and they're matched to the right door, so to speak. And that's been a really key sort of realization for New Hampshire. So thank you.
Thank you both. So this question is for all of you, and Dr. Davis, we'll start with you. You have a lot of people tuned in today, and they're representing states who are at different places in terms of implementing these requirements and in thinking about addressing the health and well-being needs of youth in a collaborative way. I'm wondering, what is the one piece of advice or one takeaway you want people to take with them as they think about how to address those underlying health and well-being needs and how to go about implementing these new requirements that frankly can seem daunting, particularly given the timeline that everyone is facing?
So I would say a few things. One, this is about having courage, vision, and goals for transformational systems change and hope and restoration for families and their youth. I would add to that caveat that disproportionately Black youth are not diverted out of these systems, nor do they necessarily receive the same quality of service. So to be mindful of that, intentional about that, and observe as you're developing the programs and be willing to say we've made a mistake and we need to revise and we need to go back. But I think that's the most important thing, because that's where we start, because that is the consumer. Corporations all the time survey their people to make sure, their customer, to make sure they're satisfied with the product. Juvenile justice doesn't do that so much, and we need to do that if we want to have the impact that we're striving for with families and youth. Thank you for the opportunity.
Dr. Strohecker.
Thank you. I would echo what Dr. Davis said and just add, you know, the value of collaboration is worth its weight in gold, really, to have the right people at the table, and then to bring your teams along to that. I think what we've seen is that our staff are so engaged in finding the path to the outcomes, right? And I feel that really early engagement, collaboration, seeing the vision, and being comfortable with phased implementation. It might seem overwhelming to think, how do I reach that long-term milestone? And it is in phases sometimes with different programs and services. When you think of the infrastructure investment and some of the transformational work that's required to accomplish this. I love the fact that we talked about like establishing the vision, defining the goals, measuring it, and using the consumer voice to really help inform the process. I think that's a critical piece. Our stakeholder work groups do always engage like the members and the individuals and have them there. There's such a valuable piece of helping us see the things that we may not see through our seat at the table, right? So I'll just add a little bit extra to that, but appreciate everything Dr. Davis said as well.
Tough to follow up on that. I would add an echo, I guess, from that. I want to reiterate, Jennifer, you just made a really key point. Family voice, youth and family voice is really critical. And for New Hampshire, having that youth and family voice as part of the development of the system of care has been critical to our expansion. Having patience, this doesn't happen overnight. Funding's always difficult, but really being patient in how that's developed is important. It does take time. It does take trust. It does take partnerships, collaboration, and so having that patience is really key. There are certainly key components to a system of care development, but allowing for the outcomes to come together based on that is really key.
I guess the piece that I want to kind of separate a little bit from is that while we're thinking about systems changes and outcome changes and what that means, and system of care development and the reentry status and the new requirements, right? Folks shouldn't get caught up in the logistics of things without thinking about the human being on the end of it that we're trying to serve, because we're in a human services field, right? And so not losing sight of the youth, their family, the outcomes that we all want for them are the reason why we invest in system of care work, the reason why we collaborate, the reason why we challenge the disparities that exist and the outcomes that we're getting, because that's who we are making the changes for. And the requirements are a way to fund them on the back end, right? So they're important, they're valuable, but the framework around them is what needs to be embraced first before figuring out the details associated with it and embracing that people deserve better and that we have a way to make that happen in the long run.
Thank you all for those insights. And, I will say that we, as a team, have been so grateful to you all for keeping us focused on the vision and the why for families and young people during the process of working with you and hearing from you on developing our report. And it's so wonderful for us that such a broad audience can hear from you as experts directly today. So thank you for that. Liz, I will pass it over to you. I'm sure we have a lot of questions going.
Yes, many. So thank you all so much for asking lots of great questions for us to choose from. So there's a few that came top of mind, and I may also defer to my colleague Joe on who we might want to have best answer some of these, but I think it touches upon a lot of the themes of the report. And so one was for states that have already have waivers that do reentry for adult mental health, there's a certain appeal to replicate that approach for kids. What should states be thinking about in terms of the ways that kids are different? In terms of behavioral health needs, in terms of their respective correctional systems? It seems like there's a risk of a one-size-fits-all approach here.
Yeah, I'd like to talk about that one, but I also wonder if Dr. Davis or others have thoughts about this. To me, some of the things that are really important when you're thinking about kind of adults versus kids in this work is kind of going back to thinking about the difference between children's behavioral health and adult behavioral health, right? And that children's behavioral health is really not just about the child, but it's about the family as well, and about the family unit. You can't actually remove a child from the family, fix the child, and put the child back. It's always about working with the entire child and family ecosystem. So you have to be really, really thoughtful and careful about how you're doing all of that work together in unison. And that anytime you remove a child from a family unit, even if it ends up being the thing that has to be done, you have to continue working with that family unit to prepare for that reentry, that reunification of that family unit. You can't stop. You don't move the child away, fix the child, bring them back. That never, ever, ever works. So you have to constantly be working with the family and the child at all times. And if you're not doing both of those things, then you're not engaged in effective children's behavioral health. So I think that's kind of like a key principle that you have to think about when you're engaged in children's behavioral health work that I think a lot of people miss when they're trying to translate adult behavioral health to a children's behavioral health care system. And frankly, the same thing's true when you're thinking about youth justice work compared to adult correctional work, right? It's the same concept there. But with that, I know Dr. Davis has thoughts on this. Others probably do as well. So I'll stop.
I'll just jump in and say you're 100% correct. The children are minor adults or little adults. They're children. They develop differently. Their decision-making process is different. Also, they've been separated from the home. Then you've got trauma there. Whether that was the intent or not, there's trauma. And reintegrating them is going to be trauma. Even with the children that I adopted, and some of them were engaged in the system, we had to have counseling when they left the system. We had to have counseling when they returned to our homes and throughout. And they're now in their 30s, and we still are seeing the effects of those separations. And so I would say be mindful of that. There is no one size fit all. All you have to do is look up and down your block. Everybody's not the same. You might be on the same block, but you absolutely have different homes and you move differently.
Wonderful. So thank you. Keep the questions coming. And while this is until 2, the formal part of the webinar, we're happy to stick on a little bit longer and to have some informal Q&A as well. So just know that. So one question that rose to the top, Joe, have any of the speakers thought about implementing these services pre-adjudication? What would need to happen for that to occur, and what prevents it from occurring?
Hey, so I thought Amy could answer this because that's what she's really doing.
I would love to. Thanks. So here in New Hampshire, we are assessing youth on using the CANS tool, the Child Adolescent Needs and Strengths tool, pre-arraignment. So pre-first appearance, before law enforcement files in our state, it's called petition. It may be a complaint. It may be an offense in other states. They make a referral to juvenile justice to conduct a CANS tool, which then drives outcomes for how that youth will be served. So the 75% of youth who are being referred either for behavioral health or community-based interventions are all pre-court. They never go in front of a judge. They never go in front of a defense. Like there's no court oversight to that in any way, shape, or form. It's well before adjudication. It's before arraignment. So there were laws changed in our state to support that work. We have data to show the outcomes associated with it, but there's a huge benefit to having youth have front-end intervention that's informed based on their strengths and needs that leads to positive outcomes without needing formal court oversight or further probation intervention.
I would love to tack on to that. I'm sorry. I think that work is just such a sort of a great example of what New Hampshire is doing. And I think even pre-adjudication, families have access to an array of services that are important to prevent a youth from even needing to get to that level, or if they're stepping out of juvenile justice system to remain in the community. So I just want to amplify or sort of echo the importance of high fidelity wraparound models, partnerships with community mental health centers, providing evidence-based practices, federally qualified health centers that are interjecting primary care settings. We've really our data outcomes are really showing that we're preventing a significant percentage of youth from even needing to get into juvenile justice to get their needs met in that way, allowing families and youth to access intensive in-home supports based on the needs that are presented through assessment. So just want to highlight that piece too.
So I just want to clarify one more piece, is that the law that I'm talking about that changed within our state creates that assessment process, which is pre-arraignment in our state, is a voluntary process as well. So it's another value in the system of care work that's been embraced to make it voluntary for the youth and family to engage in without forcing that level of intervention to see where they should be served. And we're having very positive engagement rates as a result of it being voluntary, which then further help with the outcomes that are produced as a result of the assessment.
One question that came and I answered, but I think touches upon some themes of the work that you all are doing and will be important for states to think about. How can juvenile courts and juvenile justice agencies ensure that meeting these requirements doesn't lead to children being held in facilities longer than necessary? Would love to, if you have thought about that issue at all in your states. Getting from the director, Strohacker, if you want to add.
Well, I'll just react to this. Has been brought up on both the youth and adult side, right? And I think that is the degree to which we can establish a Medicaid eligibility prior to moving into the community and building those community connections to a high level of care in the community itself, hopefully would not keep that. And I think like what we're looking for too is not just, up to the 30 days or 90 days pre-release as we're considering in Utah with regard to that Medicaid coverage and getting a high level of healthcare delivery at that time, but really that being the level of care that the youth receives in that setting throughout the duration, so that when you look at these timeframes of post-adjudication or pre-adjudication, that level of care is already established, so that if we can ensure Medicaid eligibility at that time, they can move into the community and still have those warm handoffs with that high level of care sustained into the community partnerships that we have, and hopefully address what are those concerns of lawmakers and others that may think it may potentiate the care within those settings, right? So I think that's one way we've looked at it with regard to at least helping address those gaps in care by having that more seamless transition, and then ensuring a high level of care through our contracted partners on the Medicaid side specifically, really being detailed in our contracts, our requirements, timelines, and all the requirements of care in order to ensure that the youth as they move into the community are getting the highest level of care possible that meet their needs, making sure that the policies and the reimbursement support this, so that they can be optimally treated in the community setting as well.
Yeah, the only thing I would, and thank you for that, Jennifer, I think those are the things you build within your system to try to prevent there from being challenges around implementing this. The other piece that I would just highlight within the guidance and within the law is that, if I'm remembering it properly, and Liz, you'll correct me if I misstate this, that there's language that a young person isn't to be held longer for the purpose of implementing these provisions, right? So the young person shall be released as they are supposed to be released, and the services shall be implemented once they're released, if in fact the provision of services would delay their release. So you're to still provide the services, but then you would release the young person and then provide the services. Of course, doing all of the things that Jen just spelled out in order to make sure that the young person doesn't find themselves in this situation is what we all need to be doing.
And all the great work you all have done with your system of care approaches to ensure that youth are inadvertently accessing the juvenile system when they need behavioral health care is so critical. And we emphasize quite a bit of that in the report that was linked in. So certainly eager to talk more about that, as time allows. And it's a really important question to ensure you're doing this effectively. And Daryl has his hand. Go, Daryl.
I'm sorry.
That's okay.
I just wanted to share something sort of tangible, something that it would be helpful, I think, for the group to hear. As we talked about some of that preventative work. One of New Hampshire's key initiatives was the development of a 1959 state plan amendment, which really developed a Medicaid benefit for high fidelity wraparound services, including family youth peer supports, respite codes. I won't list all of them, but that benefit package really helped us develop a step down, a transitional step down for youth in this particular population more effectively, but also from a prevention standpoint. So I wanted folks to hear about some of that tangible Medicaid work that we've done in New Hampshire.
Yeah, so what's interesting about your question is I struggle to answer it because you talked about how do we ensure youth are not lingering, waiting for the services to begin, when in our state, youth are referred for the service the day of entrance, right? So it's not even on my radar that folks would be staying, waiting for these requirements to kick in, because we have such accelerated statutory driven timelines that our youth from time of entrance to time of adjudication is 21 days. So there is not time for a youth to linger waiting for release to have these requirements be accessed, because we're doing it day one, well before this provision was instituted.
Yep, that's great. One question came up that's a little healthcare-y focused, but I think for Director Strohecker, managed care organizations are attending this webinar, which is great, and they're wondering what's their role in this work. So would love to hear how you envision that in your state in Utah as you're implementing.
Yeah, thank you for the question. In fact, the managed care organizations have a critical role in the success of this work, as they are, at least in our state, a primary provider of the Medicaid billable services, right? And including the, coordination with community partners, all the things that Daryl mentioned with regard to some of the other services that are available underneath the Medicaid umbrella. So I'd say how we are doing this, number one, is really defining the role of that targeted case management, and knowing we have targeted case managers on our juvenile justice side that are with the individual inside the facility, and as they move into the community will be that same person, but really coordinating with care manager teams on the managed care plan. So for managed care plan assignment in our state, there's a carve out of the behavioral health. So it's it's one of those bifurcated models where the physical health and behavioral health, it's challenging to navigate. And the role of the managed care plan is to really ease that burden and challenge to help a Medicaid enrolled individual and their family know, A, what are you eligible for? How do I access these services? What are my points of contact? We've talked about prior authorizations, right? So there's a lot of obligation as we've looked at our implementation steps in the context of our waiver, and we had to put our youth requirements into our waiver, and it's very patient focused. The work is very much about ensuring that the youth and their families are well aware. They know which plan they're assigned to. They know who to contact. They know what services are available to them, and are really kind of really proactively engaging folks in that work. So that's how the managed care plans are involved. And we envision that our contracts will support this level of work, level of engagement to accomplish these goals. And yeah, we're still early in our conversations, but that's the work we've outlined.
Thank you. I just want to note that it is 2 o'clock. So for those of you who need to go ahead and jump off, we thank the panelists so much for their time today, and you all for joining. As Joe mentioned at the top of the call, they have kindly offered to stay on for a little longer to answer some of these many questions that have popped up in the Q&A. So if some of you are able to stick around to have your questions answered or to listen in, you are welcome to do that.